Hi, my name is Jones Muna. Today, we discuss alcohol and substance abuse. Alcohol, ethanol, is a CNS depressant. Large amounts consumed rapidly can cause respiratory depression, coma, and death. Large amounts chronically consumed damage the liver and many other organs. Alcohol withdrawal manifests as a continuum, ranging from tremor to seizures, hallucinations, and life-threatening autonomic instability. In severe withdrawal, delirium tremens. About 45 to 50 of adults globally are current drinkers. 20 are former drinkers, and 30 to 35 are lifetime abstainers. For most drinkers, the frequency and amount of alcohol consumption does not impair physical or mental health or the ability to safely carry out daily activities. However, acute alcohol intoxication is a significant factor in injuries, particularly those due to interpersonal violence, suicide, and motor vehicle crashes. Chronic abuse interferes with the ability to socialize and work. About 7 to 10 of adults meet criteria for an alcohol use disorder, abuse, or dependence. In any given year, binge drinking, defined as consuming 5 drinks per occasion for men and 4 drinks per occasion for women, is a particular problem among younger people. Alcohol and substance abuse have tremendous social and economic costs to families and governments globally. In Zambia, alcohol consumption and substance abuse are one of the most prevalent health risk factors among adolescents and young adults. Where assessments have been elsewhere, economic impacts are in the billions of dollars and include healthcare, treatment, and lost productivity costs. In order to gain an insight of the personal and financial costs of alcohol and drug abuse, several nationwide surveys have been examined. For instance, Pollen examined the economic costs of alcohol abuse in Canada for the year 1992 as around $7.52 billion, or 1 of the gross domestic product. The biggest share of costs through substance abuse remain tobacco use, with an estimated $9.56 billion economic costs. In the United States, the National Institute of Health 1998 reported that the estimated economic cost of alcohol and drug abuse was an estimated $246 billion, of which alcohol abuse and alcoholism generated about 60 of these costs, $148 billion, while drug abuse and dependence accounted for the remaining $98 billion. No reliable estimates have been available for the cost of drug use in Germany, but Bergman and Horch, 2000, report that the total costs caused by alcohol consumption in Germany are about 40 billion marks per year. These are staggering numbers, but pale still when we begin to examine the impact of chemicals on our children and youth. Some statistics by the National Clearinghouse on Alcohol and Drug Information one time claimed that 20 of 16 to 17-year-olds used marijuana 1 to 7 days per week, compared to 12 of 12 to 13-year-olds. Alcohol is a central nervous system depressant. It plays a prominent role in the development of at least depression, and is often involved in other mental disorders. In addition, people who abuse alcohol are at increased risk of mental disorders related to nutritional deficiencies. A lack of thiamine, a B vitamin, can result in permanent brain damage in the form of severe dementia, even at an early age. People in withdrawal from alcohol are also at risk for delirium tremens, a serious condition that can result in cardiovascular shock and death. 2 most notable problems linked with alcohol abuse are withdrawal and dependency. Withdrawal state chronic effects. Tolerance to alcohol develops rapidly. Similar amounts cause less intoxication. Tolerance is caused by adaptational changes of CNS cells, cellular or pharmacodynamic tolerance, and by induction of metabolic enzymes. People who develop tolerance may reach incredibly high blood alcohol content, B. C. However, ethanol tolerance is incomplete, and considerable intoxication and impairment occur with a large enough amount. But even these drinkers may die of respiratory depression secondary to alcohol overdose. Alcohol. Tolerant people are susceptible to alcoholic ketoacidosis, especially during binge drinking. Alcohol. Tolerant people are cross-tolerant of many other CNS depressants, for instance. Barbiturates, non-barbiturate sedatives, benzodiazepines. Symptoms and signs of alcohol withdrawal. The physical dependence accompanying tolerance is profound, and withdrawal has potentially fatal adverse effects. A mild withdrawal syndrome includes tremor, weakness, headache, sweating, hyperreflexia, and GI symptoms. Symptoms usually begin within about 6 hours of cessation. Some patients have generalized tonic-clonic seizures, called alcoholic epilepsy or rum fits, but usually not more than 2 minutes in short succession. Alcoholic hallucinosis, or hallucinations without other impairment of consciousness, follows abrupt cessation from prolonged excessive alcohol use, usually within 12 to 24 hours. Hallucinations are typically visual. Symptoms may also include auditory illusions and hallucinations that frequently are accusatory and threatening. Patients are usually apprehensive and may be terrified by the hallucinations and by vivid, frightening dreams. The syndrome may resemble schizophrenia, although thought is usually not disordered and the history is not typical of schizophrenia. Symptoms do not resemble the delirious state of an acute organic brain syndrome, as much as does delirium tremens or other pathologic reactions associated with withdrawal. Consciousness remains clear, and the signs of autonomic lability that occur in delirium tremens are usually absent. When hallucinosis occurs, it usually precedes delirium tremens and is transient. Delirium tremens usually begins 48 to 72 hours after alcohol withdrawal. Anxiety attacks, increasing confusion, poor sleep, with frightening dreams or nocturnal illusions, profuse sweating, nausea, vomiting, weakness, irritability, insomnia, hypoglycemia. Insomnia, hypoglycemia also occur. Fleeting hallucinations that arouse restlessness, fear, and even terror are common. Typical of the initial delirious, confused, and disoriented state is a return to a habitual activity. For example, patients frequently imagine that they are back at work and attempt to perform some related activity. Autonomic lability, evidenced by diaphoresis and increased pulse rate and temperature, accompanies the delirium and progresses with it. Mild delirium is usually accompanied by marked diaphoresis, a pulse rate of 100 to 120 beats per min, and a temperature of 37.2 to 37.8 degrees C. Marked delirium, with gross disorientation and cognitive disruption, is accompanied by significant restlessness, a pulse of more than 120 beats per min, and a temperature of more than 37.8 degrees C. Risk of death is high. Symptoms progress proportionately to the blood alcohol content. C. Actual levels required to produce given symptoms vary with tolerance, but in typical users, 20 to 50 mg per deciliter. Tranquility, mild sedation, and some decrease in fine motor coordination, 50 to 100 mg per deciliter. Impaired judgment and a further decrease in coordination of 100 to 150 mg per deciliter. Unsteady gait, nystagmus, slurred speech, loss of behavioral inhibitions, and memory impairment. 150 to 300 mg per deciliter. Delirium and lethargy. Likely. Emesis is common with moderate to severe intoxication because emesis usually occurs with obtundation. Aspiration is a significant risk. In addition, due to prolonged use of alcohol, 3 of the following disturbances may occur. Delirium tremens occurs 2. 4 days of complete abstinence from heavy alcohol drinking and recovery is expected within 7 days. It is an acute brain syndrome characterized by clouding of consciousness with disorientation in time and space. poor attention span and distractibility, visual, and also auditory, hallucinations and illusions which are often vivid and frightening. Tactile hallucinations of insects crawling over body may occur, marked autonomic disturbance. Tachycardia, fever, sweating, hypotension, and pupil dilatation, psychomotor agitation and ataxia, insomnia with a reversal of sleepwalk pattern, dehydration with electrolyte imbalance. Alcoholic seizures, rum fits. These are generalized tonic-clonic seizures, which occur in about 10 of alcohol-dependent patients, usually 12 to 48 hours after a heavy bout of drinking. Status epilepticus may be precipitated. Multiple seizures, 2 to 6 at a time, are more common than single seizures. Alcoholic hallucinosis. This is characterized by the presence of hallucinations, usually auditory in nature, during abstinence following regular alcohol intake. Classically, the hallucinations occur in clear consciousness and recovery occurs within 1 month. Alcohol dependency syndrome. Alcohol abuse remains a major public health issue and socioeconomic problem in today's society, with a lifetime prevalence of 14. Adverse effects of alcohol withdrawal syndrome, IWS, on patient outcomes have been well documented. In addition to causing discomfort, metabolic stress, and the potential for serious outcomes, including seizures, the syndrome also impairs effective healthcare delivery to the patient. Despite great progress made in the field of psychiatry, the development of suitable medications for the treatment of alcohol dependency remains a challenging goal for alcohol research. The mechanism between alcohol intoxication, tolerance, dependence, and withdrawal is complex. In simple terms, alcohol has a depressive effect on the central nervous system, CENS. The brain adapts to this depressant effect if large amounts of alcohol are consumed over time, thus instigating a level of tolerance. Abrupt cessation of alcohol consumption causes rebound excitation of the central nervous system and consequent autonomic hyperactivity. Smith, Alnemer, and Watford, 2004. It must be stated that alcohol dependency is a cluster of physiological, behavioral, and cognitive phenomena in which the use of alcohol or a class of substances, drugs, takes on a much higher priority for a given individual than other behaviors that had greater value. The central descriptive characteristic of alcohol dependence syndrome is the desire, often strong, sometimes overpowering, to take alcohol. The notable signs and symptoms of the disorder include strong desire or sense of compulsion to take alcohol, difficulties in controlling amounts taken, and timing. Presence of withdrawal signs and symptoms when alcohol is not taken. Tremors and sweating are evidence of tolerance. Large amounts of alcohol are required to achieve desired effects. And progressive neglect of alternative pleasures or interests because of alcohol use persisting with substance use despite evidence of overtly harmful consequences. Medical, mental, or psychosocial problems. Narrowing of personal drinking criteria. Applicable and cessation of or reduction in alcohol use that has been heavy and prolonged. B. 2 or more of the following developing within several hours to a few days after criterion A. 1. Autonomic hyperactivity, sweating or pulse rate greater than 100 beats per minute. 2. Increased hand tremor. 3. Insomnia. 4. Nausea or vomiting. 5. Transient visual, tactile, or auditory hallucinations or illusions. 6. Psychomotor agitation. 7. Anxiety. 8. Grand mal seizures. C. The symptoms in criterion B cause clinically significant distress or impairment in social, occupational, or other important areas of functioning. D. The symptoms are not due to a general medical condition and are not better accounted for by another mental disorder. Street drugs are well known for their effects on young people's mood and behavior. Permanent brain damage may result from the use of some designer drugs. One example is ecstasy, which can cause permanent memory loss and severe depression that responds only slowly to treatment. Street drugs must always be considered as a possible factor in the sudden onset of a mental disorder in a young person. Moreover, drugs may precipitate a first psychotic episode in a person with a genetic predisposition to schizophrenia. In this case, the drug is the stressor that reveals the person's dormant susceptibility to the disorder. General signs or characteristics. Definitions regarding psychoactive substances. That is, substances that activate the brain and cause effects on thoughts, emotions, and behaviors. 1. Intoxication. Maladaptive behavior associated with recent drug ingestion. 2. Withdrawal. Adverse physical and psychological symptoms that occur following cessation of the drug. 3. Tolerance. The need for more substance to attain the same level of effect. 4. Abuse or misuse. A maladaptive pattern of use leading to repetitive problems and negative consequences. Use in dangerous situations such as driving. Use leading to legal, social, and occupational problems. 5. Dependence or addiction. Continued desire for and use of a psychoactive substance to satisfy pleasurable urges or to alleviate the effects of withdrawal. Dependence may be psychological or physical in nature. Psychological dependence. Persistent substance use despite evidence of its harmful consequences. Difficulties in controlling the use of the substance. Neglect of interests and an increased amount of time taken to obtain the substance or recover from its effects. Evidence of tolerance such that higher doses are required to achieve the same effect. Compulsion or craving. A strong desire to take the substance. Anxiety or mood disturbance occurs if drug is not taken. 6. Physical dependence. Physical symptoms occur if drug is not taken. G. Headache, gastrointestinal distress, changes in blood pressure, heart rate, sweating, tremors, muscular pain. B. Effects of psychoactive substances, intoxication and withdrawal are physical and psychological effects that may occur with psychoactive substance dependence or abuse. Specific symptoms of intoxication and withdrawal for varied substances that have been studied in Western societies are outlined below in the table. Medication treatments and counseling interventions are also included in the following sections. Substance abuse and dependence not only have psychological and physical effects, but also social effects. Deteriorating job, educational performance, family conflict, and legal difficulties are social problems that have been associated with substance addiction. Symptoms and medication treatment for intoxication and withdrawal associated with psychoactive substances, counseling interventions for substance use disorders. 1. Anxiety and depression may underlie substance abuse. Also, some individuals with bipolar disorder or a psychotic disorder may use alcohol or drugs to self-medicate or deal with symptoms. It is therefore important to evaluate for these psychiatric conditions and provide the appropriate treatments. For some patients, drug and alcohol use is decreased if underlying anxiety, mood disturbance, or other distress is relieved. 2. Teach breathing and relaxation techniques as a means for controlling anxiety. See chapter on Anxiety Disorders for technique instructions. 3. Encourage individuals to identify people who can be contacted for support when cravings or distress occurs. Another who is also recovering from addiction and is sober can be a good ally. Encourage the patient to make a list of and use constructive responses to cravings and distress. See example below. The point is to interrupt the craving or distress with a constructive, health-promoting response. Then, with the patient, on a regular basis. I. Discuss the emotions. B. Review, reiterate, and add more responses as indicated to the constructive responses list. C. Give praise and encouragement for following through with the constructive responses. 1. Use problem. Solving approaches to address practical issues and difficulties arising from substance abuse. For instance, financial problems, job loss, marital difficulties. 2. Self-help groups. Use the principles of the self-help group to help individuals with the common problem of substance abuse gain knowledge and support. Medication therapy. If there are any concomitant medical conditions, treat them. E. Attempt detoxification by withdrawing the drug of abuse and treating the side effects. Attend to nutritional and electrolyte hydration imbalances. If service is available, psychosocial counseling and support should be commenced once the patient's mental state is stable. Apart from alcohol, clients presenting with complications from other psychoactive substances of abuse may be referred for specialist treatment. Alcohol withdrawal. Patients with severe withdrawal or delirium tremens should be managed in an ICU until these symptoms improve. Treatment may include the following to prevent Wernicke-Korsakoff syndrome and other complications: thiamine and benzodiazepines, thiamine 100 mg. V is given to prevent Wernicke-Korsakoff syndrome. Alcohol. Tolerant people are cross-tolerant of some drugs commonly used to treat withdrawal. Benzodiazepines. Alcohol dependency. Refers to frequent consumption of large amounts of alcohol with equal to or more than 3 of the following: tolerance, withdrawal symptoms, drinking larger amounts than intended, persistent desire to reduce use without success, substantial time spent obtaining, drinking, or recovering from alcohol, sacrifice of other life events for drinking, continued use despite physical or psychological problems. Alcoholism is often used as an equivalent term for alcohol dependence, pursuing. Etiology. The maladaptive pattern of drinking that constitutes alcohol abuse may begin with a desire to reach a state of feeling high. Some drinkers who find the feeling rewarding then focus on repeatedly reaching that state. Many who abuse alcohol chronically have certain personality traits: feelings of isolation, loneliness, shyness, depression, dependency, hostile and self-destructive impulsivity, and sexual immaturity. Alcoholics may come from a broken home and have a disturbed relationship with their family. Societal factors. Attitudes transmitted through the culture or child rearing affect patterns of drinking and consequent behavior. However, such generalizations should not obscure the fact that alcohol use disorders can occur in anyone, regardless of their age, sex, background, ethnicity, or social situation. Thus, health workers should screen for alcohol problems in all patients. The incidence of alcohol abuse and dependence is higher in biologic children of people with alcohol problems than in adoptive children, and the percentage of biologic children of alcoholics who are problem drinkers is greater than that of the general population. There is evidence of genetic or biochemical predisposition, including data that suggests some people who become alcoholics are less easily intoxicated. They have a higher threshold for CANS effects. Symptoms of alcohol withdrawal syndrome. AWSE. Clinical symptoms of WS manifest with variable intensity in proportion to the amount of alcohol consumed and the duration of a recent drinking habit. Compton, 2002, suggests 2 phases of alcohol withdrawal syndrome: alcohol withdrawal and alcohol withdrawal delirium or delirium tremens. D. Beats. Frequent intoxication is obvious and destructive. It interferes with the ability to socialize and work. Injuries are common. Eventually, failed relationships and job loss due to absenteeism may result. People may be arrested because of alcohol-related behavior or be apprehended for driving while intoxicated, often losing driving privileges for repeated offenses. In most U.S. states, the maximum legal blood alcohol concentration, C, while driving is 80 mg/dL, 0.8, and this level is likely to be reduced in the future. Diagnosis of alcohol withdrawal syndrome, AWSE. Some alcohol-related problems are diagnosed when people seek medical treatment for their drinking or for obvious alcohol-related illness, for example, delirium tremens, cirrhosis. However, many of these people remain unrecognized for a long time. Female alcoholics are, in general, more likely to drink alone and are less likely to manifest some of the social signs. Therefore, many governmental and professional organizations recommend alcohol screening during routine healthcare visits. Treatment of alcohol withdrawal syndrome, AWS. All patients should be counseled to decrease their alcohol use to below at-risk levels. For patients identified as at-risk drinkers, treatment may begin with a brief discussion of the medical and social consequences and a recommendation to reduce or cease drinking, with follow-up regarding compliance. For patients with more serious problems, particularly after less intensive measures have been unsuccessful, a rehabilitation program is often the best approach. Rehabilitation programs combine psychotherapy, including one-on-one and group therapy, with medical supervision. For most patients, outpatient rehabilitation is sufficient. How long patients remain enrolled in programs varies, typically weeks to months, but longer if needed. Inpatient rehabilitation programs are reserved for patients with more severe alcohol dependence and those with significant and comorbid medical, psychoactive, and substance abuse problems. Treatment duration is usually briefer, typically days to weeks, than that of outpatient programs. Psychotherapy involves techniques that enhance motivation and teach patients to avoid circumstances that precipitate drinking. Social support of abstinence, including the support of family and friends, is important. Maintenance. Maintaining sobriety is difficult. Patients should be warned that after a few weeks, when they have recovered from their last bout, they are likely to find an excuse to drink. They should also be told that, although they may be able to practice controlled drinking for a few days or, rarely, a few weeks, they will most likely lose control eventually. In addition to the counseling provided in outpatient and inpatient alcohol treatment programs, self-help groups and certain drugs may help prevent relapse in some patients. Alcoholics Anonymous, IA, is the most common self-help group. Patients must find an Alcoholics Anonymous I group they feel comfortable in. Alcoholics Anonymous, I provides patients with non-drinking friends who are always available and a non-drinking environment in which to socialize. Patients also hear others discuss every rationalization they have ever used for their own drinking. The help they give other alcoholics may give them the self-regard and confidence formerly found only in alcohol. Many alcoholics are reluctant to go to Alcoholics Anonymous and find individual counseling or group or family treatment more acceptable. Alternative organizations such as Life Ring Recovery, secular organizations for sobriety, exist for patients seeking another approach. Drug therapy should be used with counseling rather than as sole treatment. Disulfiram, the first drug available to prevent relapse in alcohol dependence, interferes with the metabolism of acetaldehyde, an intermediary product in the oxidation of alcohol, so that acetaldehyde accumulates. Drinking alcohol within 12 hours of taking disulfiram causes facial flushing in 5 to 15 minutes, then intense vasodilation of the face and neck with suffusion of the conjunctiva, throbbing headache, tachycardia, hyperpenia, and sweating. With high doses of alcohol, nausea and vomiting may follow in 30 to 60 minutes and may lead to hypotension, dizziness, and sometimes fainting and collapse. The reaction can last up to 3 hours. Few patients risk drinking alcohol while taking disulfiram because of the intense discomfort. Drugs that contain alcohol, for example, tinctures, elixirs, some over-the-counter liquid cough and cold preparations, which contain as much as 40 alcohol, must also be avoided. Disulfiram is contraindicated during pregnancy and in patients with cardiac decompensation. It may be given on an outpatient basis after 4 or 5 days of abstinence. The initial dosage is 0.5 gram per oral once day for 1 to 3 weeks, followed by a maintenance dosage of 0.25 gram once per day. Effects may persist for 3 to 7 days after the last dose. Periodic physician visits are needed to encourage continuation of disulfiram as part of an abstinence program. Its general usefulness has not been established, and many patients are non-compliant. Compliance usually requires adequate social support, such as observation of drinking. For these reasons, use of disulfiram is most effective when given under close supervision to highly motivated patients.